Does anyone, I know we've got a lot of people here, does anyone have questions or like how this would work? Joe?
I popped in a little message. I know that I've sent Dr. Alvear a couple of images, but like at the minute for me, what's going on is I have a loop ileostomy. I have a redundant large colon that's also fallen down, and what looks to be a large stomach. So I just thought everything was severe constipation, but then after I had the ileostomy, and then I just found out by accident about this narrowing. I had very little peristalsis. So I'm wondering, like, if you have a stomach that just isn't like the normal size and stuff anymore, like, does that impact it?
Yeah.
And I don't know whether a colectomy is down the line for me.
Yeah, I think the stomach can get big if they're not emptying properly.
Yeah.
You have a gastric emptying study that shows no lack of emptying?
Yeah, moderately, not full-blown gastroparesis. However, I think it's got worse because,
So what we do with that, what I do with that is add what we call an antrotomy or antroplasty.
Okay.
Antrotomy is you divide the muscle above the pylorus.
Okay.
Above the pylorus, not a pyloroplasty. That's a bad thing to do. A pyloroplasty is when you cut the pylorus and you suture in a certain way. And when you do a pyloroplasty, what happens then is you can develop what they call a dumping syndrome of your stomach, and that's bad. You cannot reverse that. Though a lot of surgeons know that. They have no idea what that is. But when you do an antrotomy, it's like when you do a baby who had what a condition we call pyloric stenosis in a baby. If you read up pyloric stenosis, the baby has a thick muscle above the pylorus. And it's a misnomer, actually, to call it pyloric stenosis. It should be antral stenosis. But again, I can't prove that. I can't allow my forefather get out of the grave for me to say you're wrong. But it's really above the pylorus. And we don't do a pyloromyotomy, which is what the operations they call. We actually do an antrotomy. And I've been trying to fight that idea for a long time, but I can't prove it. And I didn't want to do it because I'll be against the medical establishment. But it's really the antrum. So for patients who have delayed gastric emptying, you do an antrotomy. You cut the muscle, and then you stretch the muscle to allow the inner lining, the mucosa, to bulge out.
Wow.
If you enter the mucosa in doing so, then you do an arthroplasty. You still cut the whole thing then, and then you suture it above the pylorus. And that's what an arthroplasty. And I have taught surgeons to do this before. Some surgeons have learned the technique that I've developed for that.
Okay. Thank you.
So that's what you need. So if you ever get done, anthroplasty or antrotomy be included in the procedure for you.
And I want you there.
And then once you empty your stomach, then your constipation will improve.
Yeah.
Because if you're constipated because you are delayed gastric emptying, you lose what we call a gastrocolic reflex, which is a normal reflex. Like a lot of people, including me, after I eat, I feel like I have to go to the bathroom. And some people actually go to the bathroom to have BM after each meal, 10, 15 minutes later. And of course, if you go to a French restaurant where they have a lot of sauce and everything, I have to be near a bathroom because my stomach empties so fast.
So before I got the stoma, I would have went once a month. That's how few. So they said the colon had just stretched because it's been going on for years.
Correct. Yeah. So you might still have to get your colon removed.
Yeah.
Someday, but you have to try without doing it first, and then and take care of your stomach first, and then see how your gastric emptying will improve the entire intestine.
Thank you. Thank you.
Anyone else? See a lot of, anyone else? No? A lot of people here, no one with questions?
Well,
So,
I guess my explanation was understood pretty well. Hi, Madeline.
Hi, this is Joyce.
Oh, Joyce, yeah.
Hi, Doctor. Thank you for all you do. I guess for some of us older folks who are, now facing a failed DDJ and comorbidities like nutcracker and malls,
Right.
Of course, who are diagnosed in my example, at 55 and I'm 59 now.
Wow.
And so, of course, this is all new and we've been managing this. But my fear, of course, is complications, right? Because I've had so many, and to your point, the unknown. So when we consider these surgeries, that's always my concern, for someone who's complex and who has EDS and these other things too.
Right.
And to make this decision to travel, I guess that's where it comes from is, we all have a hesitation. So what is the best advice that you can give to us who are struggling with this decision because of these past surgeries?
Yeah, it's probably best to do it locally. It's if you can find a surgeon who's really willing to take the issue, it's best to do it locally so you can take care of you afterwards and any other issues later. But certainly, we can reverse the D&J and then do the procedure that I mentioned, and that works pretty well. If you have a mild to moderate nutcracker syndrome, there's no problem that's really narrowing the renal vein, that you don't need an auto transplant. Sometimes the Alvear-Fowlkes procedure can reverse some of the mild one. I have patients who had nutcracker syndrome who had the procedure and they're fine. They don't have any issues right now. And some of the patients we've done in Virginia also have. So it depends on the type of how bad your nutcracker syndrome is. But the reversal of DJ itself is easy. We just put a staple in there, and if you can take a staple or metal, we can divide it and just sew it up, and then do the Alvear-Fowlkes procedure.
Yeah, she's a little nervous because she thinks she's old, but she's not as old as me, but she does have EDS. So, you know.
And I do have a flattened left renal vein, so it is flattened.
Okay. So in fact, sometimes that had to be answered first. That issue has to be taken care of by a transplant surgeon to put your renal vein somewhere else or do an auto transplant.
Can you when you're working in the aortomesenteric angle, can you like loosen that a little bit? The renal vein?
No, you can't. And putting a stent outside is bad because any foreign material you put in, the body will reject. It's just normal. I mean, the body will reject any foreign material.
And why doesn't it reject the staple?
Because it's titanium. Supposedly, it's supposed to be a titanium, and it's to be non-reactive.
Well, the PTFE is the same as a titanium, according to.
Okay. Then
I don't know.
I don't know, but
they use the PTFE for a lot of different things.
Yeah.
Surgery. So.
Right.
I don't want to argue. I'm just saying. I'm just saying, Dr. Alvear.
It just needs.
Thank you, Dr. Alvear.
You said a series, yeah.
I know. But we don't agree on everything, people. Okay, I'm going to ask. I'm going to ask you this question from Felicia, who says she'll be having surgery with Dr. Fowlkes, and her partner needs to travel back home after surgery. How feasible is it to be alone post-op? And what do the first few days post-op look like?
Depends on your condition. If you're a fresh case, meaning never had an operation before, and you're just going there for the SMA, and not no other condition. If you are not malnourished extremely, and you're not in narcotic too much, all that, then your recovery should be quick. And what usually he does is he puts an NG tube, and if the drainage clears up, he takes it out. Usually that's 2 to 3 days later, and then you start on clear liquids, and unless your stomach, if you're hungry after on the 6th day, he can allow you to have a little bit of muffins or something, and then you can go to a hotel, stay there for a week, and then go home later.
Yeah, I mean, most of us are pretty tough anyway.
Yeah.
And I think if you're, you know, a lot of times we see people who, and I don't want to, like, I always tell the story about when I had my DJ surgery and Dr. Marone came in and he told me, you need to get out of bed and start walking. And excuse my French, I got pissed off because I was like, dude, I just had surgery. Don't you understand that? I'm like, I don't want to get out of bed. And like, he's like, you need to get out of bed. So I just got in my little walker and I got out of bed and I was like, I'm going to walk around this hall and I'm going to make sure the nurses see me walking around the hall. So I was like, I got up and I walked and I didn't want to walk, but that's, you know, that's what makes your gut wake up and start working.
Yeah.
So,
Yeah.
you know, the worst thing you want to do is lay in bed, and it's hard. I mean, you feel like crap, but if you can really get up and start moving, even if you feel like crap, you got to get up and start moving because that's going to make you feel better.
Yeah.
It's going to make the bile stop coming out of that NG tube, which feels like a tree trunk coming out of your nose, and you know, you're going to feel better. So
yeah, that's a good idea because there's such a thing as spasm of your muscles because if you don't get up and start releasing that spasm, you'll continue to have pain. Because in the old days, we didn't used to bring our patient back until maybe a week later because you were afraid the stitches will burst, the incision will burst. But now, we as soon as you're able to walk, 6 hours later, you could. I mean, if you could do that, you'll have less pain afterwards.
I mean, they had me sitting up on the side of the bed. I'm like, and I work in physical therapy, so I realize that, you know, you get the patient up on crutches and you're having them walk so they can go home that same day. I'm like, no, this isn't right. I just had surgery. Don't you understand? And it's like, God, I have to be a patient now. I have to do this. So, yeah. So, Felicia, I think, you know, I heard the nurses are really good at the hospital.
They're good to you.
Mm-hmm.
They're all aware of your situation.
So, yeah, if you've got to be alone, and there's probably going to be other SMAS patients there. So it's going to be okay. You're going to be okay. Let me see. There's more. Somebody says they slept for the first couple of days. Is that you, Reagan? Just clarifying. Stenting the left renal vein or anything like the iliac should be avoided.
Yeah.
Marissa, I think, said that. You can stent the left renal vein and you can stent the iliac, but I think a lot of times the left renal vein has a problem if it's stented because the stent can migrate.
Yeah, the problem of the vein is it's got a low flow. It's not like an artery. So that's a problem. So got to be careful with that.
So Lowe says, it seems the Alvear procedure is successful for most patients. I want to ask if there is a common trait in patients who get worse after the procedure.
The one who gets worse after the procedure is some patients who had malnutrition, really severe ones, and who had many other complications. We we haven't done a case that had a gastrojejunostomy yet, so we're still waiting for that case. That could be a gastrojejunostomy is probably one of the worst cases. And the other thing is, because you had the people who had long-term NJ feeding, whether by open tube or by nasal, the feeding that they use for jejunum is what we call hypersmolar, which is very rich. So a normal person, our own jejunum, cannot take those rich formulas. Very difficult, because we find that because I deal with babies and we need them to gain weight, we have to be very careful when we give them any feeding beyond the stomach. It's always better to feed from the stomach and then get digested, get diluted to a normal, what we call osmolality, which is the richness of the fluid to go into the small intestine to be absorbed. So our GI guys and our surgeons who are treating patients with this, they cannot push the jejunal feeding so rapidly because they get sick. You get sick right away. I mean, many people have been sick from that. When they give you a full feeding, where it's full strength, immediately you get sick. So what they need to do is slow feeding, diluted formulas, diluted to half or a third, and gradually allow the intestine to what we call adaptation. They have to adapt to the lower formula. They have to adapt.
Nicole, do you have something to say?
Yeah.
Yes. Hi, Dr. Alvear.
Hi.
Stacey. Yeah, I just was wondering, because I'm having such problems with my colon, and I probably won't be able to see Dr. Fowlkes till, I mean, I don't know. I think they're scheduling in December. And I'm just having a lot of problems with my colon. And I wanted to do the subtotal colectomy first and then have the alvear procedure later. Is that an unwise thing to do?
It could be. I mean, if there's an indication for your colon to be removed, it can be done any time. I don't think it makes any difference, but I think first you got to find out why you're having such a problem. Whether it's a gastric emptying, or they do all kinds of tests. You can do a manometry test and see if your sphincters are working properly or your colon is moving properly. There's something called a sitz test where you swallow something and they see how long it takes for it to go down to the anus. Things like that. You gotta find out why you're having such problem with the colon, because you can temporize things with the colon. You can get saline enemas. You can give laxatives and stuff like that. I dealt with chronic constipation in kids, but I don't have to resect everybody's colon. So you got to find the right doctor who can manage your colon differently. I mean, from what you used to.
The main problem is the sigmoid part, because I did six markers and like the stool just like sits there. It doesn't move because it's so stretched out and
So
long.
redundant, yeah. Okay.
Yeah. So I didn't know if there's a chance that could improve after surgery.
It might not if you've had it for a long time. How old are you now? May I ask?
I'm almost 50.
Oh my! So that it might not improve.
Right. That's why I was.
So Dr. Fowlkes can probably consider doing it all at the same time, and I'd be glad to go help him. I mean, if he asks me.
Okay, I'm gonna try to hold out.
Yeah, I think we can do everything at one time.
Right. I know that would be the best thing.
That would be the best thing, rather than have another operation.
Right. Okay. Thank you.
Yeah.
It sounds like Felicia is quite a tough person because she's had mouths with Dr. Sue. Shoes, I always say his name wrong, in 2024.
Sue,
Then
Dr. Sue.
Sue,
Dr.
yes,
Sue. Yeah.
I know. I don't
SHSU.
how to say it. In 2024, and she's going to get a revision with Dr. Fowlkes,
Okay.
along with hernia repair. This is our appendectomy and hysterectomy.
Oh, wow.
Yeah.
Listen, good luck. I have continued to stand myself.
And EDS malnutrition, but not on opiates.
Whoa.
Not. Okay.
Well, it could be a long recovery, but you'll be fine once you get it done.
Okay, let's get to Rona, who says, if this is too long, please disregard. Sorry. My daughter has had hybrid AT, so auto transplant, May Thurner's stents, and she has delayed gastric emptying. She is scheduled with Dr. Fowlkes for SMA surgery in January. She's trying to get a local doctor to agree to learning. That's great. She's scheduled for pyloroplasty as well as Mal's release with Dr. Fowlkes. Her question is, were you saying that maybe a pyloroplasty is not the way to go?
No, it should be antrotomy. Antrotomy, angioplasty, not a pyloroplasty. That could be a problem because you can't reverse it. Once you do it, you can't reverse it.
So she said months ago she had a Botox injection in her pyloric junction, and it helped with her emptying, but her SMAS worsened.
Right. So only do an antrum. Antrum is the word.
So you have to tell Dr. Fowlkes that because she's getting that done with Dr. Fowlkes.
You got to tell him, and he's had to talk to me. Yeah. So I can show Dr. Fowlkes how to do an angioplasty or antrotomy rather than a pyloroplasty.
All right. Thank you. That's great.
So you got to get me in there.
That's good by us. Thank you.
Okay.
All righty.
Nicole, who I believe is also Ren, says she has the same exact thing. It's her transverse and sigmoid colon. Also, the markers fit in the sigmoid. So that's what she, okay.
Yeah.
So we're back to low, heard that other compressions can get worse after the Alvear procedure, which leads her to think that the changes in anatomy that is made during the Alvear procedure can be harmful for some patients that have fragile connective tissue. Could you tell us about your observation on the long-term impact of Alvear procedure on colonic function and other compressions?
Well, as far as I know, as far as function of the other bowel, if your stomach is emptying properly and you're eating and the colon is not horribly redundant and distended, that the colon should work once the Alvear procedure is done. If you don't have delayed gastric emptying to begin with, that's why we need to do a gastric emptying study. And as far as the other compression, I mean, there are people with multiple compressions, so each one has its unique problem that has to be addressed. Right.
I think that's it. Did I miss anything? Whoops, something new. Okay. Marissa said, wait, did I miss that? Marissa says she has EDS with Mal's nutcracker and May Thurner, gastroparesis, PCS, SMAS, and she's trying to get into Dr. Fowlkes as soon as she can. She's being fed by GJ. Is that not a great idea?
No, that's okay. GJ is fine. If by GJ tube and you're going to the jejunum, and if you're tolerating the formula, that's fine.
Right.
Yeah.
Oh, she said a J. Oh, GJ.
gastrostomy.
Yeah. Let's see. Okay, I heard something incorrectly earlier. Oh, is everybody okay? You guys can talk.
All set. Yes. No, I have a GJ tube, and I mistakenly heard that the feedings through the J were negative to
No.
us for SMAS, and I was like, oh no,
No.
because locally no one has any idea of
Right.
SMA.
Yeah. If your intestine is adapted to it and you can tolerate it, that's fine.
Right.
Okay.
If you have discomfort from it, pain, or all kinds of issues, nausea, diarrhea, then you gotta slow down and get back and then start all over again.
Okay. Yeah, I've only been on it for about 2 weeks. I was on TPN prior, and they just try to do the intestinal feedings to try to keep.
Yeah, nutrition. Yeah. Just if you feel awful, if they increase the rate too fast or increase the strength too fast, then your intestine has the time to adapt. It has to adapt. There's a thing as period of adaptation.
Gotcha. Okay. Thank you so much.
Mm-hmm.
It's hard. And, if you can continue to try and eat little bits by mouth just to keep your gut working. I know it's hard for some people, but I don't know. Some people find it hard and you can't eat
mashed potatoes are besties.
Yeah. Some people just give up because it's too painful, but, in the long run, I mean, it's hard if you're vomiting all the time, but okay, let's see. I missed one and come on, where's my thing? Okay. Joe said a lot in my mouse. What if you have moderate delayed gastric emptying and gastroptosis? Maybe caused by SMAS, but you don't have, maybe it's not gastroparesis. Do you need that special procedure?
Yeah, if you have delayed gastric emptying, you need to antrotomy.
Okay, but okay.
It'll get better. It'll get better in time.
Okay, so a lot of people always ask the question about gastroptosis. How do you feel about gastroptosis? I think a lot of it could be from EDS, but is that what you think gastroptosis occurs from?
Well, some of the in my original article, we felt that some of the reason for the SMA syndrome was the visceroptosis as a whole. The whole stomach and the colon, everything seemed to be dropping down.
Right.
And it became like a pendulum. We call it pendulum swing. Became a pendulum as a cause for the obstruction, but I'm not so sure about that right now, because based upon the anatomy that I see whenever we do one of these, I can't really visualize in my mind the way they depict that in journals and books, because it's difficult to do that. That's why when people do unusual operations, you can do it just by doing a drawing.
Right.
Yeah. You have to be right there. Everybody's anatomy is different.
But maybe you were seeing a lot of EDS patients and you didn't realize that that's what they had back in the day because it wasn't as well known. It wasn't
described. Yeah, it was well known. No.
Yeah.
Probably. Yes. Agree.
Okay. So let's see. Nicole says she has an NJ2, but she's still trying to eat things by mouth.
Yes.
And
you should, because by eating, your stomach produces acid and digests the food, and then it goes to your duodenum, and once the duodenum, the bile start to work. They have to be excreted to your bile ducts, and then your enzymes from your pancreas will start to work. And if you have fat that you ate, then your lymphatic system will work and start to allow lymphatics to your fat to go into the lymphatics and then go to your portal vein. So if you were people who are in long-term hyperal without feeding get the liver, actually get problem with the liver. The liver functions start to fail because 40% of your blood supply to the liver is through your portal vein, and your portal vein flow is coming from your intestine and your stomach. So if you don't eat, then and everything is bypassed into your vein by giving TPN to nutrition through the vein, then people become the liver can get injured by having that. So you got to be able to eat, and the best way to eat is through your stomach, not your intestine.
Right.
If possible.
Okay. So Jessica says, have you noticed any incidents of SOD in patients in post-op SMA surgery?
What is that?
Sphincter of Odi dysfunction.
Yes. Sphincter of Odi.
Oh, sphincter of Odi. No. I think the problem with that, the people who do a proximal duodenostomy, they have to be careful because you're getting close. The sphincter of Odi is on the second portion of the duodenum, and sometimes they're abnormal. They could be lower. There could be anomalies of the sphincter. Could be instead of the middle of the second portion, it could be in the lower. It could be located lower. So if they do the so-called duodenostomy, some people are doing, they have to be careful because they could be right in that area. So I would not recommend it. That's why we do the anastomosis at the duodenojejunectomy, away from everything, away from the sphincter, away from the pancreas, away from that.
I'm missing something. I think I am. Sorry. My mouse decided to quit on me. So Nicole says she has an NJ2, but she still tries to eat by mouth. Oh, wait. I've already passed that.
Mm-hmm.
Joe says she knows a lady who has SMAS. She said it seemed to come on from having mesh in her body.
Mesh?
Surgery? Yeah, like probably abdominal mesh.
Or for
a gynae problem. She's in London as well.
No, I don't think it's anything to do with the mesh. It won't be unless it's coincidental.
Well,
Okay.
it might, could be pulling down on her
Yeah.
abdominal cavity or something. Sometimes that,
Yeah.
you
Depends on where the mesh is. Yeah.
Okay.
yeah. So Nicole wants to know how did those of us who developed SMAS at middle age get this syndrome?
We're just finding out now. In fact, there's a person supposedly who's 89 years old. 89 years old, who was an SMAS, and so they're wondering, can we operate in that? It depends. I mean, that's really getting up there in age. So it depends how healthy that person is, because we can operate in somebody who's 100 if they think they're going to live for 110. But certainly we have to be careful. Yeah.
Oh, sorry, Felicia, I missed. She said, I have issues with bile stools and vomiting thick bile. Is that caused by SMAS, or is it likely something else entirely?
Well,
on her last endoscopy, they said her pyloric sphincter did not close at all during the 90 seconds they watched it.
Yeah, but the bile is coming from the duodenum, so it can't be from the stomach. So that means the pylorus opens for you to vomit the bile. So the bile is always, when we call a green vomit in children, we worry about blockage, obstruction. When you have a green vomit, that means you're obstructed somewhere. It has to be in the small intestine or duodenum.
So that's typically from SMAS, right?
Correct, yes. Vomiting is not the first symptom. You can only have nausea, and when you get filled up, that's when you vomit.
Which is why I don't like doctors saying you can't have SMAS if you don't vomit.
Oh,
but
no, that's not true.
I know.
Absolutely false.
Yep. Does SMAS get worse without treatment?
You can have SMAs in your life. You know how to deal with it. Like if you can maintain your weight, you don't have to gain weight. That's the other thing that we need to look into and research is the so-called you got to gain weight to get better. But I think if you just maintain your weight to be healthy, just to be healthy, you have to have maintain your weight just to be healthy, so you can walk around, you can breathe, you can eat, you can participate in activities. You don't have to gain weight to make it. Just have we call a positive nitrogen balance. You have to maintain your balance so that you can continue with your normal function. Now, if you lost a lot of weight, then you have to gain it back to get the nitrogen balance, so you can be healthy. Otherwise, if you are malnourished and lost weight, then your immune system goes down, everything goes down. Appetite goes down, your mood goes down, everything. I mean, if you're completely malnourished and have all the deficiencies in the world, then you're really sick.
Well, Dr. Alvear works with a surgeon who has SMAS.
Yes.
And he's never had surgery.
Yes.
But he maintains it by eating small, frequent meals.
Correct.
But he probably has enough of a fat pad that he can maintain. But he's probably one of those guys, if he ever got sick, really sick, he might go into what we call a flare, but he might be able to manage to eat his way out of it. You know, some people can eat their way out of it because they have that little fat pad that's hanging on. And some people just don't ever have fat pad. I don't know. That's my theory. I don't know, Dr. Alvear, you have a theory?
No, I think we don't know a lot of things. So
right.
I mean, I can say whatever you say about the fat that needs to be addressed, because they tried to do experiment where they would do a BMI test and then they would do a CT scan before and after weight gain and see if there's a difference. And there's not much. So
yeah,
they need more studies need to be done.
I mean, there's obviously extremely thin people who never develop SMAS, and then there's obese people who get SMAS. So there's a lot to learn.
Yes. Yeah.
So Joe, we're going to call this the last question, and then we will wrap it up. So Joe says, could it get worse because of having loop ileostomy surgery? And I have difficult chronic abdominal distension even before I eat. Is it likely SMAS or redundant fallen colon? I can't tell what's what.
No, that's a difficult question to answer because you don't know which one is causing that problem.
All right. Well, I'm going to ask you one more question because a lot of people have extreme bloating.
Mm-hmm.
Do you have any idea why that would occur? Why someone would just get extreme bloating after they eat?
I think it's the stomach, mainly it's the bloat. The bloat, that's why you have the so-called succussion splush. It's like if you are bloated and you just walk up and down the steps, you can hear the swooshing in your stomach with all the fluid in there. And that's when you either lie prone like a puppy dog, or you lay on your right or left side, whichever side makes it better. I prefer you lay on your right side down, and that's how you allow the stomach to empty better in a natural way, in an even gravity. Or you can go prone position, or you can actually Some people have done extreme where they would go on a stairway and have their head down in the bottom of the steps and just lay like that for a little while, and somehow that seemed to relieve the bloating. And I mean, some people have said that to me. They just go to the stairway and head down the stairs, and your legs up in the stairs, and you find which way would allow your stomach to empty.
Okay.
Amazing.
Sounds counterintuitive, but I guess if it works.
It works to some, so I can't.
I know, I'm just saying. Whatever works.
Whatever
I would think
works.
I'd be,
Yeah.
but, okay.
Mhm.
All right, well, thank you, Dr. Alvear, and
Okay.
we
Can I ask
appreciate you
one
being
last
here.
question, if that's okay?
Okay,
Okay.
yes.
So it's going to be a long question. Thank you so much for answering all of our questions in such depth, if that's okay. So I have a question regarding malrotation anatomy. So since in malrotation group, I see accounts of non-rotation patients who never had volvulus issue,
Correct.
but rather suffer from overall GI issues that worsens to the point that they seek care as an adult.
Right.
It seems that the non-rotation anatomy itself could cause the issue, or at least some providers and patients believe so. And so Dr. Kareem from Cleveland Clinic, I'm sure you've heard about him, performed his original procedure to rotate the gut and then to pexy the colon and reconstruct the ligament of Kreitz.
Right.
In order to reconstruct what is supposed to be a normal anatomy, right?
Right.
So such a procedure seems to help some adult non-rotation patients, meaning that the non-rotation anatomy itself could be harmful for some. Do you see any potential issues in the long term with creating a non-rotation anatomy through the Alvear procedure?
No, because we anchor the cecum to the left colon to prevent that, and that's actually a procedure for malrotation that was first conceived by a surgeon from Seattle, Washington, and I'm the only one who adapted it. Other surgeons still don't do that, and they have recurrence of patients with volvulus. So if you anchor the cecum to the left colon, that won't happen.
I see. Okay. Thank you very much.
Okay.
Sharon, I'll answer that for you really quickly. So Dr. Alvear, if you find a surgeon that's willing to have him come and learn from you, what he needs to be able to be approved to go into the OR. So whatever that takes. And then you are responsible for everything to get him to wherever you are. You pay all of his fees and then a donation to his nonprofit. So we get together with him and pay for him to fly to where the surgeon is. And so it's whatever that the costs are to get him there and to stay there while the surgery is being performed. And then he gets like a $5,000 donation to his nonprofit.
Thank you, Stacey. Yeah, I just wanted something I'm looking into. So yeah, thank you.
So what we're hoping, like if we could get somebody over in the UK to do that we could fundraise because there's a lot of people over there, so that we could spread that out across the platform, so that it wouldn't just be one person having to take on that,
I'm actually in Australia. So
same thing in Australia. Because we've got a bunch of people down there as well. In Australia
and
in
New
the
Zealand,
UK.
and easy enough to go to the Philippines from Australia and New Zealand.
So yes, so we're trying to find.
So until you can find a surgeon, you can come to the Philippines for your care.
Yeah, but I mean, I know it's better for you guys to have a surgeon in your country, but in the meantime, we're just trying to problem solve, because trying to get out of the country and to go to Germany, or God forbid, going to Germany I went to Germany, so I know what it's like, and going to Spain is just about the same. So that's why we're trying to figure this out to help you all. So.
Absolutely.
And there's someone,
yeah,
someone in Portugal who's trying to get me in there. So
yeah, we have people that are really working to try and problem solve this for everybody, because it's definitely difficult. And so.
Yeah, my surgeon is open to considering it. At the moment, I'm just trying to go through all the diagnostics of all the added compressions I've got. But yeah, I will speak with you, possibly Stacey, down the track if that's possible.
Okay, sure. And if you need the videos or his research or whatever else you need, just let us know and we'll definitely help you.